Welcome to the Gut Matters podcast with Casa de Sante, the virtual gut clinic. Today's guest is Dr. Marie Barter. Dr. Barter specializes in working with patients who have neurotransmitter disorders, such as anxiety and depression, as well as adrenal issues.
Hi, everyone. Welcome to the Gut Sense podcast. And today we're excited to welcome Dr. Marie Barter to the podcast. And she's going to talk to us about gut health. Welcome and thanks for being here, Dr. Barter.
Hey, thank you so much for having me. I'm really excited to be here. And so it was super fun to have you on my podcast. So I'm just glad to be here and we can do this again.
Awesome. Yeah. Looking forward to talking about gut health. And so can you start off by telling us a little bit about yourself, your background, what you do? And
So I've been in practice now for about 14 years. I practice primarily functional medicine out of Colorado. So anyway, I have two practices there. And so a lot of my practice is largely gut health. I work with a lot of neurotransmitter disorders. So basically a lot of anxiety and depression and kind of memory issues and focus, just on kind of a minor scale, as well as adrenal issues. So anyway, so that's been my practice largely for the past 14 years. And I ended up getting into this. I ended up getting into this kind of form of, and I do more natural medicine, getting into this because of my own health issues, right? So I basically had all kinds of health issues. I was having hives all over my body. I had severe IBS. I struggled with severe anxiety and just having a little bit harder time learning to read than some of my classmates. And so anyway, it sort of drove me onto this health brigade, because traditional medicine, the way it was being practiced at the time, couldn't really do anything to help me. So I was kind of left to my own devices, and natural medicine is what really helped me. So that's why I ended up here today.
Awesome. So for those of our viewers who are curious, can you, what is, in your mind, what is the definition of functional medicine, and what's your philosophy, and how do you practice it?
Yeah, so I basically use lab testing to diagnose, or not really even to diagnose, because I'm not trying to put a name on disorders. I'm just trying to figure out what's going on. For example, like, do you have low serotonin levels? Do you have high cortisol levels? And so I'm working in this gray area that generally gets missed by traditional medicine, the way that it's generally practiced in labs, right? Or in practice. So I'm kind of looking at a gray area where people haven't been able to be helped, and they're having these symptoms that are really irritating and really affecting their lives. And so my philosophy is that the body can really heal itself when given the right input. And so what I look at is, sometimes it's dietary changes, sometimes it's not. Most of the time by the time someone gets to me, which I think is all of our experiences, is that they have been through the rigmarole by the time they come and see me. So I'll generally run labs and figure out what's going on. And a lot of those are functional labs, like stool testing. And I get the question a lot, like, what would be different than the stool testing you're running versus my gastroenterologist, which is a really fair question, right? Because you've had a stool testing done. So how could they be that different? Yeah. So our testing is going to be more PCR, and it's going to be a lot more, comprehensive and more of a functional way. So we can kind of see these minor issues where it's like bloating, et cetera. But, in traditional medicine is really important for ruling out and diagnosing, but I'm practicing more in the gray area, and I just feel like the body can generally heal itself when given the right inputs.
Awesome. So for your patients with IBS, what do you typically see is how is the cause of their symptoms, and how do you typically treat them? And how long does it take?
Yeah.
Some of these people have had their issues for so long.
Totally. Well, great question. And such an expansive answer, because everyone has IBS for, I think, different reasons. It's not always the same. So a couple of things that I see, generally people come in, primarily women. They tend to be more bloated. from an IBS perspective, that tends to be one of the big things that they have had severe food restriction, severe dietary restriction for a long period of time. It hasn't really helped. And then sometimes constipation or diarrhea is what I will generally see. And so at that point, what I tend to do is I tend to run a stool test and kind of see what's going on. A lot of my patients have had a lot of traumas, most of the time sexual. So there have been a lot of sexual traumas. So that just tends to be the subset that I have seen. But there tends to be some sort of trauma going on. A lot of times it hasn't been addressed. So that is one thing that I see when I'm taking the history. Also, the other thing is that most of these folks are really eating the same foods day in and day out. They are afraid to eat vegetables. That a lot of times are afraid to eat raw vegetables. They hurt. A lot of times people will say broccoli or cauliflower, Brussels sprouts are really, really irritating type foods. And so they'll avoid. A lot of these people can't eat. And so that tends to be another symptom. So generally what I will see on stool testing is I see a lack of microbiome diversity is one of the biggest things. Some patients have H. pylori, some don't. Some patients have SIBO, some don't. The literature says about 80% of IBS patients have SIBO. I don't know if my population is quite that high. Some do, some don't. I would probably put it maybe closer to 60 is what I see in my general subset. But SIBO can be a contributing factor, which is small intestinal bacterial overgrowth. And so that really comes with bloating. I see a lot of the methane group, which is constipation. I always see some form of dysbiosis. So that is, dysbiosis is an overgrowth of maybe a bacteria that's normal in your gut that's gotten overgrown. And occasionally I see pathogens and parasites that are problematic. A large portion of the time I see leaky gut in IBS cases. I sometimes see that patients are having trouble filtering or moving things out of their system, and then also digestive enzyme problems. The other thing that I think I see that I see about 50% of the time is gallbladder issues.
Okay.
So those tend to be the big things that I see, and I feel like everyone's different and has a diverse mix of that. That is a contributing factor. With my IBS patients, I also see a lot of anxiety and depression. I think that's how I've linked some of the traumas to it. I mean, because if you're scared to eat all the time, that can be very stressful and very traumatic, and then other lingering traumas.
And it's a cycle. Yeah, you're scared to eat and you don't eat, and you're stressed out because you're not eating, and then you eat and then you're scared to eat, and it just goes on and on. Yeah.
Mm-hmm.
So wait, there's so many diverse causes of IBS, like as you've just stated. How do you tell so is this two tests enough for you to say, this is the cause, or you have to run more tests?
It depends on what they're presenting with. I generally start there. I ultimately like to run something called a micronutrient test to kind of build their system back up. But if they've got all kinds of dysbiosis in their gut, or they've got a parasite, or they've got a pathogen, I don't really want to be feeding these critters all of that. So I wait to do that. Occasionally I run food sensitivity tests afterwards. I personally like an elimination diet better than a food sensitivity test, but sometimes when I get stuck and I can't figure out what the food is, I will recommend that, but I will not run that until after I have cleaned and fixed up the gut, because it's awkward to hand, because you're doing an immune system check, and it's super awkward to hand somebody a food sensitivity test and like you're reacting to 300 foods because I haven't gotten rid of enough of what's going on in the gut. So I personally won't run food sensitivity tests at the beginning. The folks that I see are a little too reactive. I know for some people that works, but I just don't. And then sometimes I'll run, if I suspect mold, or something else going on, I will run some mold testing, or I'll do like an organic acids test to kind of see just a baseline of what's going on with their stress levels and their neurotransmitter levels. Something that I have found that has worked for me in practice has been if someone's so stressed out and they're so upset and they are just life is not good, they're not motivated, they feel worthless. If they're in that kind of type of stress, it's hard to get some movement on the gut, especially if they're having die-off and certain things don't feel super great for them. So I actually treat sometimes with neurotransmitters early on to get more movement in the gut. And so neurotransmitters are like serotonin or dopamine. I know you know all this, but for serotonin, for example, it helps with your gut motility through, and it helps you be a little more happy, have a little more resilience with pain, and just not be in that state, because you don't want to feel, if you already feel bad, you don't want to feel worse. And I've just seen a correlation in my practice that a lot of the folks that come to see me have low neurotransmitter function, also have kind of a blotted down stress or adrenal response. So I kind of look at all of those things, and I'll run basic labs sometimes. Just it kind of depends on what someone's presenting with.
Okay, great. And so typically, how long? And I know it varies from patient to patient, costs and whatnot. But if when you take over a patient, how long does it should they typically expect to start feeling better? Because some of these IBS patients or SIBO, they've had the symptoms for so long and they want to feel better yesterday, pretty much.
Yeah, it doesn't work like that. Wish it did. Yeah. So a lot of times, it really depends. Some people are like better within a couple weeks. They're kind of the outliers, to be honest. They'll feel better. And what I tell people, is by the time they get to me, there's a lot of things that are wrong by this point. So I'm like, so fixing the gut generally takes me about close to a year, because I have to kill off the critters. And so I use herbs, so it takes me a little bit longer. And then I have to repopulate and rebuild the gut. Most people are pretty great, and they've incorporated foods back into their diet kind of at that 8-month mark. Like they've reincorporated, they feel pretty good, they're not having any symptoms anymore. But I continue some of the things like prebiotics and some of the vegetable diversity and things like that kind of long beyond. I think within the first month, people notice a change. So in my really hard cases, people notice like a 30% change after the first month, when they're able to eat more food, they're able to eat more quantity of food, just as we start to do the die-off reaction. But it depends. Sometimes gut health is tough because, funny story, person was pretty much better at 6 months, went to Mexico for something and picked up a pathogen, right? And so you can't live in a bubble, so you also can pick things up. So it's not totally a linear process. I think one of my hardest cases, I ran a stool test, and there was everything. You could see SIBO. I can see SIBO on a stool test somewhat. It's not like a perfect picture. You generally do a SIBO breath test, but I saw SIBO. There was so much dysbiosis, a parasite. There were pathogens, E. coli, severe, good bacteria was low, leaky gut, digestive problems, and beta-glucuronidase, everything. And so I think in the stress in this person's case was so high. So after, I think, 2 months of being on antimicrobials, and I'm scratching my head, she was like, yeah, I feel like, I don't know, 10% better. And I had her on a lot of things, and I'm like, 10%, I'm missing something. There's something that I'm missing here. And to me, I wasn't addressing the stress piece, which was primary, which I think was allowing everything to overgrow. And as we addressed the stress piece, and as she addressed some of these issues that she had that were long-term in therapy, like her gut got tons better. So it wasn't just the antimicrobial piece that we needed to work on in the rebuilding. It needed to be outside of my treatment. So it depends, but I generally say, about 8 months is when we're really you're going to feel totally different and not ever scared, not scared anymore. And you're going to feel a lot better.
Yeah, so it's a long haul. It could be a long haul. Yeah.
It's a long haul. Yeah.
Yeah. And so you talked about die-off earlier on. During the die-off phase, and this is a question I get asked a lot. Like, patients on therapy with a practitioner and they're having sort of symptoms getting worse and worse or something, and is that because of die-off, or should a patient expect to have any symptoms, after taking the antibiotics due to die-off?
Yeah, I mean, I generally, so, I do antimicrobial herbs. I think you're treating more with antibiotics. I think it depends. I try to get folks to a point where they're not having severe die-off. So I try to dose it appropriately to not have that happen. Some people are very sensitive, and they've been through a lot. And so, for example, like stress is a big factor with this, right? So if you have two people, you give them the exact same protocol, and one person isn't getting better as fast and they're having severe die-off symptoms and they're super stressed out at their job. I see that be a contributing factor, or they don't have support at home, or something else is maybe going on that's contributing to that. What I personally do is I warn folks about die-off because I think they should know, and I have them contact me if they feel terrible. So if they can't work, I'm like, you may have a headache for a couple days, you may feel kind of bloated, your bowels may change. That's all normal. But if this gets to a point where you're miserable and you're not pooping, you need to contact me and let me know. And so most of the folks that I see they're having the severe die-off symptoms aren't eliminating well. And so that can be a contributing factor, or I have them dosed too high on antimicrobial herbs, or it's too much. And so I pare that back so that they don't have a terrible experience. So that's why it's kind of more a marathon for me than a race. I mean, and certainly, with die-off, you can do some binders that help to bind some of that up. But sometimes those can be constipating for some people when you're using the binders, or, so for example, like you could use charcoal or you could use fiber. But in a case like SIBO, fiber sometimes does not feel great if somebody has, a severe SIBO infection. So that kind of makes it a little more complicated in the initial dying off phases of something like SIBO.
Yeah, talking about SIBO, what is your thoughts on treatment and diagnosis of SIBO? Because it sometimes can be really tricky to diagnose. And so how do you approach diagnosing patients with SIBO? Or do you sometimes just treat, thinking, okay, it's SIBO, based on what you're hearing from the patient?
Yeah, so there's signs and symptoms, certainly I think that people will kind of lead you in that direction, for some of the signs and symptoms of it. Again, a lot of the times I see a methane-based SIBO. I occasionally see a hydrogen-based SIBO. In general terms, this is not true across the board, but a methane-based SIBO, they're going to be more constipated, more bloated, and then in a hydrogen, a lot more diarrhea, but it's not that clean all the time. So sometimes I'll see somebody that's constipated that has a hydrogen base. Anyway, long story short, so what I do for diagnosis is one of two things. If I suspect SIBO, I have a conversation with the patient that I suspect it, and like the gold standard for diagnosing SIBO is a SIBO breath test. I a lot of times run a stool test because it gives me more information outside of SIBO on how to fully heal the gut. There are some markers on the stool test that I use that will look for methane overgrowth. But it's kind of tricky, right? Because because I'm looking for a small intestine infection and I'm testing the stool, which means that SIBO cases can get missed if that's, my only reliance. So I basically say, hey, if I suspect it, I treat with antimicrobial herbs for it, or if they're kind of close on the line and I've seen enough comparative tests to kind of know where that line is on numbers. And so that's what I do. And then I treat with antimicrobial herbs for generally somewhere between 6 weeks and 3 months. At 6 weeks, it's generally pretty good. And I keep them on pretty low dosage of the herbs. And then, so that's what I do. And then I start to repopulate their gut at about the month point when that is down to bring their good bacteria up. And that's what generally works for me. And I don't have too much in the way of additional ones, except I will say if I miss mold, if there's mold in on the case, like you'll have a chronic SIBO infection or other pathogens. So sometimes if someone has a chronic SIBO infection, I want to know what maybe could be higher up on the food chain that could be contributing to that. I personally do not do a low FODMAP diet, and I'll tell you why. So what my experience was in practice is that if I do a low FODMAP diet, people when they bring back in those foods, they start to get bloated again. So I personally do the antimicrobial herbs. I do the FODMAPs to tolerance, whatever they can tolerate without getting bloated. And so, so I basically will kind of limit that a little bit so they're not too uncomfortable. But I have found that the bacteria hide when you go on a super low FODMAP diet, and I can't get rid of it. That's just been my experience. And so that's kind of how I treat it. So I just have them eat FODMAPs to tolerance.
So you don't see any role for the low FODMAP diet at all in your SIBO protocol?
I just that's just not how I personally just don't, because I just can't get rid of it as well. I think the low FODMAP has great results. It's just pretty strict. I feel the same way about the elemental diet.
It is. I agree.
And so it's I definitely see, some people have gotten great results with doing it with antimicrobial herbs. I think other people have had a hard time. And so that's just been how I've worked it. Who knows, that may change in the future, but that's been what I've done for a while. I was sort of, Dr. Pimentel he's kind of the foremost SIBO expert on, he said the same thing. And I was like, that's what I've had such a hard time with in practice. And so I had reverted back to not doing a low FODMAP diet because the case is just, it kept on coming back, but that's just been my experience, and everyone's an individual. So
that's definitely, I think that's one of the things that people have different thoughts about it, using the low FODMAP diet or not. So it's good to hear your experience with that in SIBO. And what do you see a role for probiotics or prebiotics in your therapy at all? Or do you say patients should not take either of those during therapy?
I do. I mean, I definitely start with short chain fatty acids pretty early on. Pretty early in treatment, and I start with what they can tolerate. I generally wait to add in, depending on the case or depending on what's going on, 1 to 2 months with probiotics, but I think they're super helpful as long as they're not irritating to the system. But yeah, I definitely see a role. When I incorporate it in, is somewhere between 1 to 3 months within SIBO treatment. And I think it works. Some people, and I also am a fan of, like, if they can tolerate it, if they have a system that's intact and they're not having problems with histamine, they're not having too much, I will incorporate fermented foods if they can tolerate them later down the line, to the amount that they can tolerate if it's not bringing up symptoms. What I generally start with, kind of to repopulate the gut, is some blended raw veggies. That's So I basically recommend that folks eat a different raw vegetable blended every day. And that actually helps to, as long as it's not too painful or hurts their
Yeah.
gut, that helps a lot. It takes I people that come in to see me that have heard me say that their gastrointestinal issues are 80% improved by the time they see me. So I feel like that little tidbit helps a ton of people pretty easily.
Yeah. And then when do you see, what do you do for patients who have relapses? So do you see a lot of that in your practice? Because that's one thing a number of SIBO patients complain about.
Yeah, the relapses. I think that what I have found, the relapses, it seems like something is higher up on the totem pole. So, a SIBO case relapsed that had a C. diff infection and a parasite after Mexico travel. So I've
Yeah.
seen that. I've also seen mold be a huge contributor to a relapse, to a SIBO infection. Stress is another thing that's a big relapsing piece. And I think it just, so I guess I kind of see what's there, and I have people rerun the testing if they're relapsing to see what we need to treat, because sometimes I get surprised, but the big thing that I've seen as a relapse is that someone's being exposed to mold or they have something higher up on the food chain. So that's generally what I see. And I try to shift their diet. I also look to see what they're eating, and I really look just see if I can change the diversity of what they're eating as well, and see if there's anything that could be triggering. But yeah, mold's a big one for my practice.
So is there any way to prevent relapse, or
any way to prevent it? Oh, I don't know if I can prevent anything in practice, but I think the biggest thing is building up the good bacteria in the gut, is, and making sure you're hitting all those, making sure you're dealing with all the extenuating circumstances, the stress, the, et cetera, all of those things that you can deal with, food sensitivities, et cetera. But, I don't know if there's 100% of the way, but I've had great luck just building up their good bacteria after I clear out their bad bacteria. I really like short chain fatty acids, and I really like diet diversity. Those two things most people seem to do pretty well with.
Great. Thank you so much. Just a couple of things. I just want to get your tips for some things that patients complain about, which is, one of them is diarrhea. That is very debilitating. Stops people from going out doing things. Do you have like a tip for people to just plug it in temporarily, at least?
Yeah, binders help. So, so some of the things that I found with diarrhea is sometimes folks need fiber to kind of slow down and bind. Sometimes they don't. Sometimes it makes it worse, and it makes it, it makes it even worse. The other things, sometimes diarrhea is associated with actually being more constipated. So, I mean, sometimes, that can be coming out because someone's a little more constipated and they're not moving their bowels super duper well. The other thing, you can do that is really helpful for diarrhea is, things like bentonite clay or activated charcoal to help kind of slow that down. But there's something your body's trying to get out, whether it has something like a pathogen or a parasite or something. Maybe it's a food that you're eating that your body's like, nope, so I think like looking at all of those pieces, one big thing that I've seen with diarrhea is keto diet's pretty popular. It's pretty popular diet, and so people are having, and some people just tend to not be able to handle, I think, so much fat at a meal for a variety of different reasons, and so one thing. A patient of mine was having severe diarrhea all day, couldn't make it through a work meeting, and she was having bacon and MCT oil and
Oh, wow.
sausages or something else for breakfast. And like, so as we took the fat level down, she was totally fine.
Oh, wow.
So, I mean, sometimes it can just be fat. And so I think something to look at to see,
Yeah.
how you're assimilating and absorbing fat is, are your stools sinking or are they floating? Because if they're floating, that is straight through, and probably on the right side by your rib cage, that quadrant there is going to be a little tender to touch. And so there might be some problems going on sort of in the gallbladder liver region. And so, I think addressing those things and potentially playing with consumption, but I see that a lot of people are potentially just tweaking the diet a little bit can do a lot for that.
Yeah, I hear you. I think that probably there are a lot of people who have diarrhea who have ongoing gallbladder problems as well. So, definitely, definitely.
Yeah, and I think even carbohydrates too, trouble processing carbs. I don't know what you've seen, but when I'll see it on a stool test, and it'll just be like the pancreatic enzymes aren't flowing because there's just a lot of sludge or stone where you can't get some of those enzymes out. So gallbladder is very, very important. Very important.
Yeah. So, thanks a lot, Dr.
Yeah.
Barter. I really enjoyed having you here and hope to have you again to talk some more about gut health and SIBO, IBS, and so much of the functional gut disorders. So where can people find you if they want to follow your work, reach out to you, have questions?
Yeah, awesome. So so you can find a lot of the information on drannmariebarter.com. That's without an E. And then you can also check out the Gut Health Reset podcast, and our practice website is all there. So I don't really do much with social media, guys. So you can really pretty much find me on my website and on my podcast.
Awesome. Thanks again, and have a good one. Take care. Thanks for coming.
Thanks for listening. Find out more about today's guest and episode in the show notes at Casa de Sante's website, casadesante.com.